Good afternoon. I'm Eric Fearon, the Emmanuel N. Maisel Professor of Oncology, Director of the University of Michigan Rogel Cancer Center, and today's moderator. I'm delighted to have you join us. Today, we're here to discuss how to assess your personal cancer risk and what you can do to reduce that risk. It's National Cancer Prevention Month, so our panel of University of Michigan health experts wanted to share the latest information with you so that you can take steps to protect your health. Thank you to everyone who sent in questions in advance for our experts to address. We'll also take some live questions as time allows after the panelist presentations. If you're watching this live on Zoom, you can submit your questions at any time using the question and answer button at the bottom of your screen. Our panelists are all leaders in their fields and dedicated to making a difference. And it's my pleasure to introduce them. Joining us today are Dr. Todd Morgan, the Jack Lapidus Professor of Urology, Dr. Melissa Paluski, Clinical Associate Professor of Surgery and Ambulatory Care, Clinical Chief, Dr. Elena Stoffel, Clinical Professor of Internal Medicine and Service Chief. At this time, I'd like to give each of our panelists the opportunity to talk about their specific area of expertise. Following their presentations, we'll begin the question and answer session. First, I'd like to welcome Dr. Todd Morgan to discuss testing and screening for prostate cancer. Welcome, Todd.
Hey, thanks so much, Eric. This is a great chance to speak with everybody about the topic that's really important to me, and I know it's really important to many men and their families. There is so much misinformation out there about prostate cancer, and I'd like to talk to all of you for a little bit about where things currently stand with early detection and a little bit about prevention. Next slide, please. So I want to start by just giving a sense of scale. People tend to hear that prostate cancer isn't all that aggressive, and it often isn't, but still, next slide. If you look at the incidence of prostate cancer among men, it's the #1 most common cancer among men in the US. And next slide. And it's the second leading cause of cancer-related death among men. And so this is a really important fact. Next slide. And the good news is that we have a blood test, PSA, which really helps us identify men at risk. And so this is a slide that shows rates of different cancers over time. And prostate cancer is shown in blue. And you can see that starting in about the mid-1990s with PSA testing, the rates of death from prostate cancer, and that's what we're looking at on the y-axis here. The rate of death of prostate cancer has declined steadily over time. This is a big deal. It's a lot of it is due to the advent of this PSA blood test. Next slide. And so, you know, many men, and we'll talk about who really should undergo PSA screening for prostate cancer. Many men are very familiar with the PSA test, but they're also very familiar with the fact that it is a highly imperfect test. And so even though it has saved many lives, there are a lot of men who have an elevated PSA but no cancer. So there are false positives, and that leads to many downstream tests, and it leads to sometimes treatment for very low risk prostate cancers that are not life threatening. It causes stress. There's something called overdiagnosis, which is when we detect a prostate cancer that is so non-aggressive that it is unlikely to lead to any kind of harm. And actually, there are a lot of prostate cancers that meet this criteria. And really, our goal when we do early detection or trying to identify prostate cancers early is not to identify those cancers that are going to be harmless, but to identify those cancers that are potentially harmful. Next slide. And so when do we recommend to begin screening? Well, it really depends on somebody's risk of developing aggressive prostate cancer. So in general, we think most men should start PSA testing between the age of 45 and 50. But some men are at higher risk of developing aggressive prostate cancer. And so who are those men? Patients who are Black or African American, patients with a strong family history, not just of prostate cancer, but also we think about breast cancer, ovarian cancer, pancreatic cancer, and colon cancer. And those men who have some type of hereditary predisposition or hereditary reason why they may have a greater risk prostate cancer. And that's something that's carried in their genes and passed along with each generation. The most famous of these genes is the so-called BRCA or BRCA gene. That stands for breast cancer. It's the BRCA, but it's actually an important gene that also causes prostate cancer. And I know Dr. Stoffel will be touching more on that. One other little fact that many men don't know is that an early PSA, say around the age of 40 to 45, is something that actually predicts the likelihood that somebody may develop prostate cancer in the future. So if it's slightly elevated, and that slightly elevated means above about 1, that doesn't mean that somebody has prostate cancer, say in their 40s, but it means that they are at higher risk in the future of developing prostate cancer. Next slide. This slide summarizes the current general guidelines for who should undergo PSA, or really who should undergo further testing after an elevated PSA test. And I'm not going to spend a lot of time on the details here, other than to say very roughly a cutoff is a PSA of 3 is considered elevated. And for men who are at high risk of developing prostate cancer, they should have continued screening every year, even with a PSA below 3. And for men who are at average risk or lower risk, and they have a really low PSA below 1, they may not need annual screening. Next slide. What do we do when we find an elevated PSA? Well, we used to go ahead and recommend a prostate needle biopsy for anybody with an elevated PSA. That is no longer the case. And so for most patients who have an elevated PSA above 3, we recommend some additional test, either an MRI test or another blood test beyond that's not PSA, something else that may give us more information than the PSA alone, or a urine test. And if one of those is abnormal, then we would go on and recommend a biopsy, which is how we diagnose prostate cancer. Next slide. At University of Michigan, we run numerous clinical trials to try to improve how we diagnose prostate cancer. And this is an example of one that's opening up here soon. It's trying to figure out, is an MRI the best next test for somebody with an elevated PSA, or is another test, and in this case, something called MPS2, which is a urine test developed here at the University of Michigan, would that be a better approach for a man with an elevated PSA? And then moving from there to potential diagnosis. And so that's an ongoing trial, or really it's a trial that's just about to open that we're really, really excited about and funded by the NIH. Next slide. Another program we have been running here, this is in collaboration with Dr. Stoffel, is a screening study just for patients who are at particularly elevated risk of developing prostate cancer, like those patients with a BRCA mutation. And again, I'm not going to go into the real details here, other than to say that for those patients at risk, we're trying to understand, is a lower PSA threshold, for example, a PSA of 2, more appropriate in order to make sure that we diagnose aggressive prostate cancer early on. Next slide. When do we stop screening? There is no really single hard and fast rule, but generally, because prostate cancer tends to be slower growing, let's say, PSA test in somebody who has a life expectancy less than 10 years is not very helpful and generally is not likely to save a life. In addition, a patient with a PSA less than 1 who's, say in their 60s is really unlikely to develop prostate cancer, and they may be a good candidate to stop screening. Next slide. Today we're talking about prevention, and I wish we had more data on how to prevent prostate cancer, and wish we had specific supplements, or some really clear recommendation on how to prevent prostate cancer. Unfortunately, there's nothing that is really compelling beyond these kind of general sensible recommendations, including maintaining a healthy weight, eating a healthy diet by reducing red meat and reducing processed foods. This appears to be particularly important, increasing fruits and vegetables, also prioritizing sleep. We often say to our patients, the #1 cause of death in somebody with prostate cancer is heart disease. So when we're doing something that's good for our heart, we're undoubtedly doing the best thing that we can to extend life and also reduce risk of prostate cancer. Next slide. Just a quick note that there is a lot of misinformation out there. And so be careful what you're reading. There is some data around the amount of misinformation for for men with prostate cancer. And one more slide, and I'll get to, I think, wrap up here. So in conclusion, screening for prostate cancer is important, saves lives. There are ways of screening smarter than just a blanket screen everybody and a biopsy for anybody with an elevated PSA, so we can tailor based on somebody's risk of prostate cancer. And addressing these potentially modifiable risk factors is really important. With that, it's really a pleasure to get to introduce Dr. Paluski, who helps lead or who leads our breast cancer program, which is truly an amazing program. Dr. Paluski.
Great. Thank you so much. I'm thrilled to be here. We're going to shift gears and talk about breast cancer, which is really, I think, a timely and important topic for Cancer Prevention Month, because unfortunately, breast cancer remains the most common cancer diagnosis in women. There we go. You can see the numbers here on the left of the slide. Each year in the United States, we see over 300,000 cases of both invasive and non-invasive breast cancer, about 1% of those being diagnosed in men. In the middle here, you see the odds for women being diagnosed with an invasive breast cancer in their lifetime of 1 in 8, which equates to a 13% risk of lifetime development of breast cancer for average risk individuals. But we know that not everyone's risk is the same. Here we consider lifetime risk of greater than 20% to be elevated or high. And what we know is that there's a large population of women who are at increased risk, estimated to be about 15% of the adult female population. And there are a number of different factors that can increase someone's breast cancer risk. I've shown kind of a laundry list of risk factors here. On the left are things that we may have control over, and on the right, those that are non-modifiable. But you'll see things like lifestyle factors, exposure to chest wall radiation at a young age, that's typically in the context of treatment for childhood malignancy. On the right, having a family history or genetic predisposition that we heard about, having dense breast tissue on your mammogram, or having a breast biopsy that shows atypical breast cells. All of these are taken into consideration when we are working with an individual to think about risk assessment. Where does someone fall on that spectrum of risk? And one of the first places that we start is looking at a robust family history. We know that in the United States, most breast cancer is not genetic, but about 10% are attributed to a gene that was passed on from your parents. And so understanding if somebody meets criteria to test for these genes is really important, because we can identify individuals who are at very elevated risk. And that changes what we do in terms of screening and the options we have to reduce risk. So on this slide, I'm showing some examples. There are a number of genes that we know are associated with breast cancer development, but you'll see wide variation in the risk with each of these. On the left in the red bars are very high-risk genes. We heard about BRCA1 and 2, which are the most common breast cancer-associated genes, associated with lifetime breast cancer risk of upwards of 70 to 90%. That's really high when we think about that average risk, the line that you see at the bottom here of 13%. Like everything, there's a middle group with these moderate to high-risk genes in orange, and then a group in blue that are more modest, things like CHEK2 or ATM, where we surpass that 20% lifetime risk, but not nearly as high as what we see with a BRCA gene. So understanding where an individual's risk is really important when we think about the next step, which is our screening recommendations. Mammogram remains really the cornerstone of screening for breast cancer. And in the table here, we have a number of different societies in the United States that have put out their recommendations. And the most common that we see is starting once a year mammogram at age 40. And that is the recommendation that we follow. And this is for average risk women. So the question becomes, well, for individuals who have those other risk factors, what do we do? And there are a number of different, sorry, we're going in the wrong direction here, imaging modalities that we may include. So we continue with mammogram once a year, but then we may add something like a breast ultrasound, an MRI, or something called tomosynthesis, which is a 3D mammogram, or even newer technology, CESM, which stands for contrast enhanced mammogram. That's a newer imaging modality that we use here at Michigan Medicine. And so when we're counseling patients, it's really identifying risk and then which of these imaging modalities makes the most sense for screening. And the reason is that we have studies showing that supplemental imaging in high-risk women are associated with detection of earlier cancers. The study shown here looked at women with a genetic predisposition and compared those who had mammogram alone or mammogram with the addition of MRI. And we see improved outcomes with the addition of breast MRI now in a number of studies that have made that a standard screening recommendation. For women with a lifetime risk greater than 20%, both mammogram and MRI are standard recommendations. But what I show on this slide is that unfortunately, this remains really grossly underutilized in the community. And the first study looked at over 420,000 women who were undergoing routine mammogram screening. And the authors identified those individuals who met high-risk criteria. And of those, only 6.6% were also undergoing MRI screening. And similarly, in a survey of primary care doctors, when asked about screening recommendations, only 12% recommended an MRI in addition to mammogram for high-risk women. So this has really provided a need for ongoing education and awareness for providers and individuals to understand optimal screening based on their risk profile. And screening is essential for early detection, but obviously it doesn't do anything to change overall risk. So when we think about risk reduction for breast cancer, I've put this into 4 buckets that we'll walk through, looking at lifestyle modification, medications that block or reduce estrogen, preventative surgery, and then I'm going to touch on just a couple of areas that I think are quite exciting going on in research. So first, if we think about lifestyle factors in breast cancer risk, most of the data that we have look at alcohol consumption, obesity, and exercise. In regard to alcohol consumption, the data show that women who drink more than 1 drink per day on average have a modest increased risk of breast cancer in the future. Obesity is a well-known risk factor, in particular for postmenopausal breast cancer, and exercise is independently protective, so reduces risk by about 20 to 30%. And if we focus a little bit more on obesity here, we know that this is a growing problem, not only in the United States, but globally. And it is now estimated that upwards of 30% of all postmenopausal breast cancer is attributable to obesity. So really highlighting another area of need for education and awareness and trying to identify best practices to help individuals with weight loss and weight management. And I mentioned medications. So this is really the main medical option that we have in thinking about breast cancer risk reduction. The other term that you'll hear for this is chemoprevention. So medications that reduce or block estrogen. And the most common drugs here are tamoxifen, raloxifene, or aromatase inhibitors. So these are medications that we use routinely to treat breast cancer, but lots of data showing that they are also very effective at reducing the risk of breast cancer forming in high-risk women. And although they are quite effective, we know that many patients who meet criteria for these medications opt not to take them. And that may be because they either don't have adequate information or counseling on this as an option, or what we've seen in studies is that there is a strong fear of side effects for individuals who are not sick or don't have a current cancer diagnosis. And so there has been a lot of work to try and identify better ways to educate individuals, as well as looking at more non-toxic options for risk reduction. And then at the other end of the spectrum from risk reduction, we think about the role of preventative surgery. And in this context, we're talking about bilateral mastectomy with the goal of reducing as much breast tissue as possible. And in high-risk women who undergo bilateral mastectomies, we see a risk reduction of about 90 to 94%. So very effective. And in the United States, about half of all women with a BRCA mutation opt to undergo risk-reducing surgery. But clearly, it's not the right choice for everyone, given the potential side effects and change to body image and sensation. But currently, those are the options that we have. And so I want to just touch briefly on what is being studied. I think in the coming years, we'll have some really interesting options to hopefully discuss. And the first is an area called topical chemoprevention. So I mentioned that we have effective medications, but they cause other side effects. And so the premise here is studying these same drugs that are applied as a lotion to the breast itself, so that we're treating the organ of interest, but avoiding those systemic side effects. And a really interesting area of ongoing research. Another area that we are participating in studies is looking at how we can actually individualize the dose of a drug that we use. The previous slide used standard dosing, but we know that the lower the dose, the fewer the side effects. And so we are enrolling patients on a trial to see what's the lowest dose that appears to be working based on changes that we see on a mammogram for each person. And lastly, I just want to mention that there are a number of ongoing studies looking at the impact of bariatric surgery or medical weight management, as well as prescribed exercise doses and how that impacts breast cancer risk, with the ideal that in 5 to 10 years, we could have a lotion that we apply, a lower dose, or an actual amount of exercise that we have proven to reduce someone's breast cancer risk. And so with that, I thank you for your time. And I'd like to end these presentations by turning things over to Dr. Elena Stoffel, who's going to discuss prevention through risk assessment.
Thank you very much, Melissa, and to our audience. I'm delighted to be here with you today to talk a little bit about progress that we've made in early detection and prevention of colorectal and other gastrointestinal cancers. And specifically, my focus is going to be on the importance of family history of cancer, as it can guide us in strategies for early detection, not only of gastrointestinal cancers, but actually of breast and prostate cancers as well. So next slide, please. So this is the slide from the American Cancer Society that reports estimated cancer deaths for 2025. And so we've talked a little bit about how lung cancer remains the highest cause of cancer death in the United States, followed by prostate cancer in men and breast cancer in women. But next on the list are colorectal and pancreatic cancers, which are responsible for roughly between 8 and 9% of cancer deaths for both men and women. Next slide, please. The good news is that early detection can actually reduce the number of colorectal cancer deaths. And as a gastroenterologist, I can tell you that it is very, very exciting to see that the overall colorectal cancer incidence and colorectal cancer deaths have decreased in the past 30 years since we've started doing colorectal cancer screening. And the reason for that is that if we find a cancer early, we can resect it, and depending on the stage of the cancer, it can be successfully treated and in many cases cured if we find it before there's distant disease. But as a gastroenterologist, it's also incredibly rewarding that by removing colorectal polyps during colonoscopy, we can actually prevent many of these polyps from growing into cancers. Almost everyone will develop colorectal polyps over the course of their lifetime. Not all of these polyps become cancers, but the vast majority of colorectal cancers started off as polyps. And if we can find these early, we can prevent them from progressing. Next slide, please. So who should be screened for colorectal cancer? And I think that although I mentioned that we have many successes in colorectal cancer early detection and prevention, there is a very sobering trend that colorectal cancer cases are increasing dramatically among young people. And in fact, the American Cancer Society just published their data last month, demonstrating that colorectal cancer is now the leading cause of cancer death among individuals under age 50. So in response to this trend, national guidelines have now lowered the age of colorectal cancer screening from 50 to 45. And so everyone who is at average risk for colorectal cancer should be screened for colorectal cancer starting at age 45. There are a variety of tests for people who are at average risk. There are stool-based tests, there are blood tests, and there is colonoscopy. And colonoscopy is the best test for people who are at increased risk for colorectal cancer. But what impacts our risk for colorectal cancer, and what determines how early we need to have colorectal cancer screening? Because some people would definitely benefit from screening before age 45. Next slide, please. So if there's one take-home message from my talk today, it's know your family history and talk to your healthcare professional about your family history, because family history provides a number of clues for our screening recommendations, not only for screening for colorectal cancer, but also for breast cancer screening and prostate cancer screening, as you heard previously. So this is a diagram of what we call our family pedigree, where circles represent women, squares represent men, and people who are shaded are individuals with cancer diagnosis. So here is an average 45-year-old woman who comes to her doctor and talks about her family history of cancer. And in this case, she has no history of cancer in her siblings, no history of cancer in her parents, but her uncle had prostate cancer at 75, aunt had breast cancer at 64. And looking at this person's family history, when they ask about their risk for colorectal cancer, they would be considered average risk for colorectal cancer and would be able to be screened with any of the modalities that we discussed previously, either stool-based tests, which are non-invasive, blood tests, which are not quite as good as stool-based tests, but better than no test, or colonoscopy, depending on their preference. Next slide, please. However, if now we look at a different individual with a family history that is quite different. And this individual has 3 siblings with colorectal cancer, one of whom was diagnosed at age 48, a father with colorectal cancer at 61, and several paternal aunts and uncles with colorectal cancer or other cancer types. This is a dramatic red flag. Next slide. And this individual needs to have immediate colorectal cancer screening, if not done already, but they also meet criteria for genetic testing for a potential hereditary cancer syndrome that would have a dramatic impact on management. So this slide gives us some red flags for identifying individuals whose family history meets criteria for genetic testing. So young people with cancer are candidates for germline genetic testing for cancer susceptibility. Individuals who have had multiple primary cancer diagnoses, for example, breast cancer and ovarian cancer, and individuals who have multiple family members who are affected with either the same type of cancer or related cancers, like families in which there's breast and ovarian cancer, colorectal, uterine, and endometrial cancer. And most recently, a family history of pancreatic cancer in a first-degree relative also meets criteria for germline genetic testing. Next slide. So for this individual whose family history I just showed you, this individual has a history of Lynch syndrome. And Lynch syndrome is one of the most common hereditary cancer syndromes. It's actually equally as common as BRCA1 and BRCA2, but most people haven't heard of Lynch syndrome. And so next slide, please. Lynch syndrome has dramatic impact on what we do for medical management. We recommend colonoscopies starting between the ages of 20 and 25, as well as other cancer screenings for gynecologic cancers and other cancer types. But I think that this slide actually shows us a little bit about where we stand in terms of what we know about genetic risks for cancer. The 2 most common genetic cancer syndromes are hereditary breast ovarian cancer with BRCA1 and BRCA2 alterations, and Lynch syndrome with alterations in the DNA mismatch repair genes. What's important to know is that these conditions are much more common than we first imagined, and that population-based studies have suggested that as many as 1 in every 300 people walking down the street may have hereditary breast ovarian cancer syndrome or Lynch syndrome. In addition, there's a lot of overlap between these cancer conditions, and there are other cancers that we may need to consider in people who have family histories of cancer that identify particular gene alterations. So pancreatic cancer is where we've made a lot of progress lately, and we know that up to 1 in every 10 pancreatic cancer patients has a germline genetic alteration that's associated with cancer risk. And this information is really important for other family members to know, for not only the management for the patient with cancer, as well as other family members. So next slide, please. So for example, in this family, this 45-year-old has a parent, a father with pancreatic cancer diagnosed at age 45, as well as a paternal uncle and a grandfather and a grandmother with pancreatic cancer. Next slide, please. So this individual, genetic testing actually identified a mutation in the BRCA2 gene, which now identifies this young woman as at increased risk for breast, ovarian, and pancreatic cancer. And for individuals meeting these criteria, pancreatic cancer screening is now being offered with endoscopic ultrasound and MRI. And we're one of the centers that does the screening here at Michigan Medicine. Next slide, please. So most individuals who are at genetic risk are unaware of their risk. And so how do we find these folks? Well, the answer is we search systematically. It's really important to talk to your healthcare professional about your family history of cancer because there can be many clues as to potential genetic risk for cancer. We now screen a lot of particular cancer types to look for features of Lynch syndrome as well as BRCA. And then finally, genetic testing for individuals who are eligible. Next slide, please. So here at Michigan Medicine, we've worked very hard with other centers in the state to try to improve access to genetic testing. And as part of one of our NIH-funded studies, we initially identified that more than 80% of people who had genetic testing in Michigan were women with a personal and family history of cancer. So we know that it's really important that everybody understand their family history and ask questions about whether their family history meets criteria for genetic testing, because hereditary cancer goes way beyond just breast cancer. Next slide, please. So where are we going? And I think that, as you've heard today, Rogel Cancer Center is doing a tremendous amount of work to try to educate both patients, families, and clinicians about modifiers of cancer risk and genetics. We are working on implementing effective tools to better identify people who are at increased risk for cancer. Family history is a good tool at our disposal, but also innovations in high-quality endoscopy and identifying other tests that can enable us to do more early detection of cancers. And finally, genetic testing, which is near and dear to my heart. In terms of discovery, you've heard Dr. Paluski and Dr. Morgan talk about how we're identifying better ways to find cancers early, as well as clinical trials for cancer control and prevention, looking at modifiers of cancer risk. And we're really excited about the potential of exercise and dietary modifications to decrease our cancer risk. But we're also working on strategies to harness the power of our immune system, such as vaccines, to try to not only treat cancers, but hopefully prevent them in individuals at high risk. And certainly looking for other medications that may be also able to decrease cancer risk is also a focus of many of our clinical trials. So on that note, I want to thank you for your attention, and I want to pass it back to Dr. Fearon.
Great. Thank you so much, Dr. Stoffel, and thank you to Dr. Paluski and Dr. Morgan for their time today and insights. They have all three have exceedingly demanding schedules, and we're extremely grateful they were able to join us today. We'll now be pivoting to the question and answer session, and I'd like to note that our presenters can't give personal recommendations at this time, but they can provide general advice and response to the questions that are posed. And we'll first start the questions with some that have come in, but we welcome you to submit additional questions to the question and answer function in the video link. So one of the questions that we had, and I'll ask each of the experts to comment in their given area, there's been great progress in cancer improving cancer survival. So now the 5-year survival rates collectively for all cancer types exceed 70%. But one of the questions here is about cancer rates. Are they rising? And perhaps we'll ask Dr. Morgan first, and then Dr. Paluski and Dr. Stoffel to comment on the incidence of prostate, breast, and colon and rectal cancers. And Dr. Stoffel, I think, commented already on pancreas, but circle back on that with regard to their incidence and whether they're rising or whether they're relatively steady or decreasing.
Yeah, so in prostate cancer, there's been a significant rise over the last 10, 15 years. And I showed that figure at the beginning that stated about 330,000 men are being diagnosed each year with prostate cancer in the US. About 15 years ago, that was under 200,000. And why is that? Prostate cancer is complicated because we have this test, the PSA test that I mentioned, and the more PSA tests we get, the more prostate cancers that we find. But clearly there are other factors that are causing this, and we all want to know what are those factors, and we're still working on it. We don't know the answer, but the incidence is rising.
And I will chime in from a breast cancer standpoint. Across the board, we do see a small increase incidence, about a 1% per year increase in overall breast cancer incidence. But uniquely, we're seeing a bigger jump in young women, where there's a increasing incidence in the youngest cohort. And there's a lot of information looking at the why, to Dr. Morgan's point. I mean, some of this is an aging population in terms of overall incidence, but there's also theories that as the population as a whole is getting more obese and delaying childbearing to older years, those are things that do impact breast cancer incidence overall. And so just lifestyle is probably attributed to some of that change in incidence.
And I think with respect to colorectal cancer, I mentioned that over the past 30 years, overall incidence and death from colorectal cancer has actually gone down in people over the age of 50. But we are now seeing a really sharp increase in incidence and mortality from colorectal cancer in people under the age of 50. And the reasons for that remain unclear. About 1 in every 5 young people with colorectal cancer has a genetic susceptibility underlying that, but that means 4 out of 5, we don't have a good explanation. And I think, as Dr. Paluski mentioned, there have been questions as to whether the rise in obesity may be related, or whether it might be something that might be related to both obesity and cancer risk. And certainly there's some data looking at diets, particularly diets that are high in ultra-processed foods, that may be pro-carcinogenic.
Great. Thank you so much to each of you. We had a question that sort of falls into the category of when looking at a given patient's risk, which is obviously complex because if you've seen one patient, you've seen one patient and their family history and personal history. But maybe each of you could comment on when you start to think about genetic testing. I know Dr. Stoffel, you commented on this, but perhaps, and as did Dr. Paluski, maybe you can talk a little bit not only about germline genetic testing, but there's increasing incidence in tests that are referred to as circulating nucleic acid based tests, I guess, as a whole, as well as other approaches that are out there in terms of full body scans and other things like that. So without going too far in the weeds and too much time, since they're really complicated subjects, maybe each of you could give some sense of how you think about a given individual's risk and family history and making guidelines or making suggestions about how you think their care plan should be informed.
Sure.
I could
Go
ahead.
Yeah, I'll start.
No, you go ahead.
Not much about this. So for, to the simplest version and the one I want to get across is that for any person with metastatic prostate cancer, genetic testing for the hereditary kind of genetic testing, germline genetic testing is recommended. For patients with localized, meaning prostate cancer that has not spread outside the prostate, anybody with what we call high risk prostate cancer, so that means the grade of the prostate cancer is at the high end, they should be recommended to undergo genetic testing. And the third component is anybody with prostate cancer, any strong family history of these cancers that we've talked about, not just prostate, but breast, ovarian, pancreatic, and colon cancer. Other types of genetics, the main component would be looking at tissue. So that means a prostate biopsy or the prostatectomy or a metastatic biopsy, and doing sequencing of that tumor in the setting of metastatic prostate cancer, potentially to guide personalized therapy. And so that's kind of the other dimension of this that I think is important to know.
And I'll give a small version on breast, and then Dr. Stoffel will let you kind of expand more. So, similar to Dr. Morgan's point, for breast cancer, women with triple negative breast cancer should be tested for genetic mutations, because that can impact some of not only our treatments, but there's a higher link between that type of breast cancer and having an abnormal gene. But we really rely on a robust family history. So understanding, as was mentioned, the number of individuals with these different cancer types. And in my mind, this is breast, ovarian, pancreas, and prostate. And then there are, other cancer clusters. The age at which people were diagnosed, so a younger family member is more of a red flag. And we have guidelines for this. The NCCN has a long list of guidelines that we use to identify individuals who meet criteria. The other things that are being mentioned from Dr. Fearon about blood tests within the breast cancer space, that is really investigational. So there are studies looking to see if we can detect earlier cancers by doing a blood test in addition to a mammogram, but that is not ready for prime time right now.
And then just to wrap up, I think that there have been a lot of changes in the field of hereditary cancer syndrome genetic testing in the past few years. I think one of the most important ones is that there's been really an expansion of the indications for genetic testing, as well as a decrease in the cost for testing. And as Dr. Paluski mentioned, there are guidelines about who meets criteria for genetic testing for hereditary cancer syndromes. And in addition to what has been described, anyone with colorectal cancer under the age of 50, anyone with pancreatic cancer at any age, and if that person is not available, then any close relatives of the person with pancreatic cancer are eligible for germline genetic testing. I think the big answer is talk to your healthcare professional about your family history and ask specifically if your family history meets criteria for genetic testing, because more and more insurances are covering the cost of genetic testing. And even if insurance doesn't cover the cost, it is available for most people at a cost of $250 or less. So I think that this is something that we're really trying to get the information out there, that genetic testing can really help you get more information about what cancer screenings are right for you. And with regard to some of the other blood tests, the multi-cancer early detection tests, I think I agree with Dr. Paluski that these are not quite ready for prime time because many of these tests have more false positives than actual true positive tests. While we offer whole body MRI to some of our individuals who have genetic susceptibility to cancer that puts them in with a cancer risk of 80% lifetime or more, whole body MRIs also turn up a lot of false positives. And so certainly at this point, we would not recommend them for individuals who are at average risk.
Great. Thanks to all the panelists. These are hot topics when you're asked by colleagues, friends, family, what should we do to do for screening? But I think as Dr. Stoffel and Paluski and Morgan have highlighted, our knowledge is evolving, but I think the guidance that they've offered is really the hard sort of truth at the present time. And there's great excitement about the future, but a lot of work still to do. So I think great takeaways. One question that I got in here, and I want to include it because how did screening recommendations change by age? For instance, in older individuals, and maybe we'll circle first to Dr. Morgan and then Dr. Paluski and then Dr. Stoffel for their expertise in each of these areas.
Yeah, so with prostate cancer, it's interesting because prostate cancer risk increases with age. It becomes more common with age, but also PSA levels tend to naturally rise because the prostate itself is growing, not because of cancer, it just grows in size, and that leads to a higher level of PSA. And so what we tend to do is we tailor what PSA level we consider to be abnormal based on age. And so the threshold rises with age. And then beyond some age, and there is no single set age, although very roughly we think about it starting in the 70s, we think about decreasing the intensity of PSA tests, meaning getting it less frequently, and eventually stopping PSA testing altogether, because usually when we identify a cancer based on PSA testing, we're saving a life maybe 15 or more years down the road. And so that's a difficult conversation, but an important conversation for us to have regarding how helpful PSA testing is beyond a certain age. A lot of people ask, well, look what happened to Joe Biden with metastatic prostate cancer, with under the best care possible. And it's really important to highlight that, yes, prostate cancer still can develop, and that and it's terrible for us to find metastatic prostate cancer at the time somebody presents. Of course, we don't know the history of his PSA testing, so that's a question that comes up a lot. But still, the important thing I think is always coming back to the guidelines, which are based on really just strong evidence.
Yeah, and I'll comment, I guess, just on both ends of the spectrum. So I mentioned that typically screening starts at 40 in average risk women. There are definitely high risk women that should start screening before that. Those are typically individuals with a genetic risk or with people with a family history of breast cancer at a young age. The other end, in terms of the older age, I think is more complicated. And there isn't a defined age at which to stop. In the table I showed, some suggest 70 to 75, but typically we look at this based on an individual's life expectancy. That if someone has a life expectancy of less than 10 years, then potentially finding an early breast cancer may not have an impact on their life. I will say in reality, lots of people aren't having a regular conversation with their providers on a annual basis about what their current life expectancy is and whether that would change their screening recommendations. And so that becomes, really a nuanced conversation about when that would be appropriate to stop.
I completely agree with Dr. Paluski. In the field of colorectal cancer screening, after age 75, we have a discussion about the risks and benefits and about what an individual's life expectancy is. Certainly in the field of pancreatic cancer screening, it's very important to decide that if we were to find something on screening, would our patient be interested in undergoing a major surgery for that? And if the answer is no, then that's when we stop screening.
Great. Thank you to each of you for your very thoughtful comments. It's a lot of interest in risk reduction as you discussed, and there's some questions here in around how diet, lifestyle, other exposures might increase or potentially, as you've already highlighted, decrease a risk of cancer. I'll start where perhaps the most evidence goes, which will be starting with Dr. Stoffel and Dr. Paluski, and then pivot to Dr. Morgan, and maybe he can offer some concluding thoughts in prostate cancer as an example.
Well, there's some really exciting data demonstrating that exercise can not only be good for your heart and your bones, but it can also decrease your risk for developing cancer and can actually improve your survival from certain cancers if you exercise actively. So I think for many reasons, exercise is a really strong recommendation, and it doesn't have to be a ton of exercise. It can be very limited exercise, even 15 minutes 3 times a week. I think that with regard to diet, I mentioned a little bit about the data that are emerging on ultra-processed foods, and what the mechanism for this being associated with increased risk for gastrointestinal cancers remains to be elucidated. But I think that we know that some of these ultra-processed foods actually change the composition of your gut microbiome, and that your gut microbiome does a lot of really important things to regulate inflammation in the body. So I think we also are learning more and more about healthy diets, and I think that the question about what is a healthy diet continues to evolve. But I think everybody's coalescing around the fact that ultra-processed foods are probably not very good for us, and if we can stay with less processed foods and fruits, vegetables, and lean meats and fish.
Yeah, and much of this is true and in parallel with breast cancer. There are specific obesity-related cancers, breast and colorectal being 2 of those main ones. So from a dietary standpoint, I often will tell patients it isn't a specific food or a magic thing to include or remove from your diet, but it's a diet that allows you to maintain a healthy BMI and to avoid or work on impacting your overall risk for obesity. And this has opened a huge area of interest in terms of obesity modifiers. I mentioned briefly work in bariatric surgery and medical weight management. There's a lot that we're going to learn in the next couple of years about the impact of drugs like GLP-1s and how that will impact a lot of these obesity-related cancers.
Yeah, well, I'll just add that, I mean, a lot of what we know in prostate cancer, we've learned from the colon cancer field and we've learned from the breast cancer field. Our level of evidence is not quite the same. And it's really, we see it as a big problem that we don't have higher level evidence, because it certainly is the #1 question that we get asked, especially for somebody with newly diagnosed prostate cancer. What can I do to mitigate my risk, to lower my risk? And so we give these same recommendations. no processed food or limit processed foods, get sleep, minimize stress, which is always easier said than done. We've just been diagnosed, for example, with new diagnosis of cancer, and the doctor saying, well, minimize stress. But it's really, we think, important to figure out what strategies work for you as we step back and try to diminish your risk.
Great, thank you. Really important guidance from all three of you. So thanks so much. One of the questions in that we received was around how should patients, families avail themselves of screening? How should they begin those discussions with their primary care provider so that they can better understand whether it's indicated for them and how they might pursue it? So maybe we'll start with Dr. Stoffel, and each of you can weigh in on how perhaps even cascade testing, which is an acronym, but maybe Dr. Stoffel and Dr. Paluski and Morgan can comment on that concept and why it's so important in families.
I think this is a really important point, and I always encourage patients and families that when they see their doctor to basically ask the question, how does my family history impact my risk for cancer, and what can I do differently? And that will often start the conversation, that they'll ask you specifically, who's had cancer in your family and what are you worried about? And then that should generate the assessment from the primary care doctor as to whether there's more cancer here in this family than I expect to see just by chance. And as Dr. Paluski and Dr. Morgan mentioned, family history of cancer does impact the ages at which we start screening for breast, prostate, and colorectal cancer. So even that having that question will generate that first assessment. And then secondly, ask your doctor specifically about whether your family history meets criteria for genetic testing, because that'll often prompt them to think about it. And we definitely want to put this at front of mind in terms of cancer prevention and early detection.
Yeah, and I will just add that while we have additional supplemental screening for high-risk women, the basis is that we should be reminding all of our family members and loved ones and friends and neighbors to get a mammogram, right? Start with baseline screening, which is the most important. And then for, individuals who know that they have additional risk factors, completely appropriate to ask if they meet criteria to add an additional test on top of that.
And for prostate cancer, also just ask your primary care doctor. There's a lot for primary care docs to cover in a visit, and PSA testing may not be something that is prioritized in every clinic. And so just ask, and I'm sure they'd be happy to go over the evidence and discuss its appropriateness for you.
Great. Well, we're coming near the end of our time together, and I want to ask each of the panelists to think of how their careers have been impacted by the support of our partners that play such a key role in supporting our ability to do cutting edge research and move those discoveries to improve patient outcomes, quality of life, and length of life. So Dr. Morgan, perhaps you could go first.
I mean, philanthropy is the lifeblood of our research. We apply for grants all the time. A lot of our work is funded by grants, whether it's from the federal grants or from foundations, but there are always huge gaps. Those gaps are at the start of a project, they're between projects. So we've had big NIH grants where we get the grant, run a big trial, but the funding it specifically covers 80% of that trial. And it's a bit, we're almost done with an important 800 patient trial that we think is going to be highly impactful. It was funded by the NIH, but they said, okay, we'll fund 80% of it. And so we have to make up these gaps. They come up all over the place. And when we have kind of early investment in projects, it leads to often NIH funding down the road. And it allows us to do pivotal trials. We also have been fortunate to have funding of our clinical program through the Weiser Prostate Cancer Center, which has really enabled us to, we believe, develop kind of a first-in-class prostate cancer center that's very patient-oriented, has incredible educational materials online, and I'd highly recommend it for anybody who's looking for information on prostate cancer to go look at our Weiser Prostate Cancer website. Thanks.
And I will second, I think that this is a unique shift that we have all seen recently, that in the past, a lot of partnership really helped with our research endeavors. I know that I have benefited from this and being able to run breast cancer prevention trials, and that is just so important. But it's also really added a tremendous amount to how we treat patients right now. And I've been wildly impressed with the support that we've had, and we have been able to develop now the Weiser Family Center for Breast Cancer, which has been a huge catalyst to get additional support that is allowing us to improve patient-centered care delivery. We are opening a new robust high-risk breast program, which is something that is so important to me because of partnership that we've built. And that I think is a tremendous asset and something that our patients are all going to benefit from.
And I will add that here at Rogel Cancer Center, we've been offering pancreatic cancer screening to high-risk families for over 15 years. But before that, but before 2 years ago, most insurances wouldn't pay for pancreatic cancer screening because they said that there's no data to prove that this is effective. So through the work that we've been able to do here, we've been able to compile the data with people from all over the world that now demonstrate the survival benefit of pancreatic cancer screening in particular high-risk families. So through the support of philanthropic dollars, we've been able to implement some of these care changes that have actually improved access to care for people throughout the country.
Terrific. Well, first of all, I want to thank all those in the audience who've joined us today. It really means a great deal that you were able to spend time with us today. I want to thank those who submitted questions, and hopefully we addressed some of the questions that you had. I'm sure there are many that we weren't able to address, and you may have additional questions arising based on the presentations and the question and response period. I want to thank all three panelists for joining us today, Dr. Morgan, Dr. Paluski, Dr. Stoffel, for sharing their valuable time, their expertise, and their insights. I think it's really been an inspiring and empowering conversation. Gives us all more insights into how we can protect our health, as well as how research is advancing at Michigan Medicine and in the Rogel Cancer Center. And finally, I'd like to extend gratitude to the community of donors and partners who support us in so many ways. And thanks to those who plan to support the Rogel Cancer Center Fund for Discovery that we linked in the chat. Your gift to this fund will help support our cancer research across Michigan Medicine. We'll follow up with everyone who registered for today's Well Aware with an email on Monday that includes a recording of the webinar so you can watch it again, along with a list of resources discussed today. Please feel free to share the recording and resources with friends and family. And finally, I encourage you to visit the Well Aware website to stay informed of quarterly webinars. Thank you for your time, and go blue.